Welcome everyone tonight to the AO Spine North America webinar on primary tumors of the spine. I'd like to say good evening, but I know this is being recorded and other people are tuning in from all over the world. So we'd like to welcome you. We have basically a 1 hour webinar with some very interesting talks tonight. I'm going to spend about 5 minutes giving us the lowdown on what's going to happen. And then we're going to have a number of didactics. And if you'd like to get questions, I'll show you how to put questions in so we can make this interactive. Oops. So I'm the moderator. My name is Dan Shuba. I know a number of you through AO and others who I haven't met. Welcome. Hopefully we meet someday in person, not just online. The speakers tonight are going to be Ross Green, who was our spine fellow at Northwell and Hofstra this past year. Dr. Lowe is one of my partners and leads our spine tumor surgery division within our department. And together we challenge each other on a daily basis about how to really take care of these complex patients. And so obviously we have a lot to share with his experience and his wisdom as well. Just so you know, Wednesdays, 8 p.m. Eastern time, Eastern Standard Time in the United States, there are going to be these topics coming up. May 25th is going to be Complications and Lemur Ramifications in Spine Surgery by Keith Jackson. The 24th of August will be Lateral Antibodies. What is the right answer? When is it troubled? By Doug Orr from the Midwest. September 21st, Historical Lumbar Trauma for John Shin from the Northeast. And November 16th, Role of Navigation, Robotics, and Spine Surgery will be Dr. Ali Baj from the West. So we have a completely covering all the time zones when we do this. When we think about these webinars, you know, they are Tuesdays at 8 p.m. Standard Time, and the next one will be as we said, well, this is a webinar that's coming out similar to ours, Advances in the Management of Decision-Making Around Degenerative Cervical Myelopathy by the very well-known Michael Failings in Toronto, Canada. And just so you know, in terms of the content validation statement by AO North America, AO North America is an independent nonprofit surgical specialty association society dedicated to improving the care of patients with musculoskeletal injuries, and it does not endorse nor promote the use of any specific product or commercial entity. And there is no equipment in this course. In terms of Zoom etiquette, please keep your microphones muted and video cameras off. Send your questions, as I was alluding to the Q&A box, and we'll try to get to those. We appreciate those questions and we'll try to get to them. If I can answer them online saying, hey, the speaker already said this, we might do that. Or if there's not time, I'll try to answer it myself. If there is time, I get to ask the faculty. Use the chat staff. There you go. Overview. In this webinar, we'll discuss basically the broad pathologies that make up the family of primary tumors of spine. It's a really big thing. I know people think of primary tumors as being really rare, but it's a huge topic. We're going to try to distill it in an hour. We're not going to obviously boil the ocean and cover everything, but to build your knowledge base and to properly help you work these patients up, and then discuss some of the principles about how to treat them with surgery, without surgery, and if surgery, how to do it safely. So by the end of it, we hope that you've built a differential diagnosis. You'll be able to apply certain principles like the Enneking, understand some nuances with regards to the type of surgeries that we employ for this, known as en bloc resection, which you hear about. And then, of course, understand that it's not all surgery in a lot of these cases, but a combination of multidisciplinary approaches. And so, I'm finishing up in my 5 minutes, right on time. And Dr. Ross Green is going to start with the introduction of the primary tumors and the differential diagnosis. And then he'll continue, maybe he'll take a glass of water and take a break. We'll have questions that come up, we may be able to answer them. And then we'll do a general workup. And then Dr. Lowe will begin talking about really surgical planning, and then other options for when is en bloc feasible. And also actually really adjuvant therapy. He's going to talk about some of the adjuvant opportunities so that we're not thinking only from a surgeon's point of view. Questions will be at the end. And like I said, send them into the Q&A. And thank you again for enjoying this. And if you're seeing this, if you can't make the whole thing, remember this is going to be recorded. And so you can come back and watch it over and over again if you enjoyed it. Thank you so much. With that, I'm going to stop sharing.
All right, good evening. As Dr. Shuba mentioned, my name is Ross Green. I am the current fellow here at Northwell Health here in New York. And so I'm going to start out this evening giving an introduction of these primary tumors of the spine, as well as a quick whirlwind tour of differential diagnosis, including some imaging, and we'll discuss some of these with recent case presentations towards the end. So when I think of spine tumors, I know we have a mix of orthopedic and neurosurgeons here today. Spine tumors will mostly be discussed, or will be discussing tumors involving the bone, but we do need to remember inside of the bone there is the dura, and within that the spinal cord and associated nerves. And so we do have intradural intermedullary lesions as well as intradural extramedullary lesions, whether in or outside of the spinal cord. However, today we'll be focusing on the extradural tumors, which are primary spine tumors. When we think about these, we have both benign and malignant tumors. We'll do a slight overview of some of the main ones here, but this is a list of a broad differential diagnosis of both the benign tumors ranging from hemangiomas to osteoid osteomas and osteoblastomas, as well as aneurysmal bone cysts. And then malignant primary tumors, we think of myeloma and plasmacytoma, chordomas, sarcomas, etc. Quick introduction. Primary tumors of the vertebral column are relatively rare. We have on average about 7,500 new cases diagnosed each year in the United States, in comparison to about 90,000 new metastatic spine tumors. So much less common than metastatic, as I'm not too surprised. I don't think anyone's too surprised about that. It equates to about 10% or less of all bone tumors. Typically, these spine tumors are diagnosed in younger patients when compared to the metastatic disease that we see in adults. When we think about common benign tumors, hemangiomas tend to be the most common. That's about 10 to 20% of the population actually is found to have these in retrospect with autopsy studies. And multiple myeloma and plasmacytoma are known to be the most common primary malignant tumors of the spine. We'll talk more in detail later on, but in general, the most frequent initial symptom on presentation, if these are found by symptomatology, it's progressive pain. Classically, it's defined as pain at nighttime. Patients do have neurologic deficits. That's seen in up to about 50% of patients. That typically is, or that will be due to involvement of the neural elements, whether it's the epidural space or into the neuroforamen. Age predilection, just to sort of help when you see these tumors and you have patients of different age ranges, it can start your mind thinking of what this tumor might be. The younger populations, these typically are more benign, though Ewing sarcoma and osteosarcoma are quite common in the younger population. And as patients are older, these are the more malignant tumors, though hemangiomas are quite common. Anatomic predilection as well, when you're looking at radiographs in the anterior column, other than metastases, which we discussed last month, multiple myeloma, chordoma, hemangioma are some common lesions that are found anteriorly, whereas in the posterior elements, those are tumors such as aneurysmal bone cysts, osteoblastoma, and osteoid osteoma. So we'll discuss some of the common benign tumors first. This is a quick chart from the Atlas of Neurosurgical Techniques that gives a bit of a differential of the benign tumors and some of the common radiographic findings, as well as a differential based on age range. So we'll start with hemangiomas. These are benign vascular tumors of the bone. They typically involve the vertebral body, as I mentioned previously, and there's a picture on the top right with some of the classic findings there. These commonly present as incidental findings, whether it's a workup for a trauma or other pathology, and then these are seen by the radiologist incidentally, though people can have them present primarily with symptoms such as pain due to pathologic fractures. Diagnosis is made radiographically. We see these lytic lesions, and as you see here in the following slide, they have very characteristic vertical striations that you see in the vertebral body there. Pathology can be obtained if it is. Typically, it shows cavernous lesions, and they're very thin-walled blood vessels, since, as I mentioned, this is a vascular tumor of the spine. Treatment is typically conservative, especially when these are found incidentally, though if patients have progressive pain, they might require surgical curettage of the lesion, as well as potentially arthrodesis if the pain is related to spinal instability. We have an X-ray and some CT scans here showing those characteristic striations as I showed. And an MRI We have a T2 on the left and a T1 MRI on the right. We see that these are hyper intense lesions on both studies. Moving on, osteoid osteomas and osteoblastomas. One of the first differentiators of these is size. Osteoid osteomas are small, they're less than 2 centimeters, and when larger, they're osteoblastomas. These are solitary blastic lesions, typically found in the posterior elements. Overall, osteoid osteomas are about 4 times more common than osteoblastomas. These are more commonly found in long bones, though about 10 to 20% of the small osteoid osteomas and 40% of the osteoblastomas are found in the spine. Sort of these kind of buzzwords when I think of these tumors in terms of the presentation of pain. As I mentioned, many of these present with pain. Classically, osteoid osteomas respond to NSAIDs for their pain. Interestingly, a range of about 25 to 62% of these patients do have associated scoliosis. As I mentioned, younger population is affected by this, and some patients actually have painful scoliosis as a diagnosis with this underlying lesion. So a most common cause of painful scoliosis in adolescents is actually these tumors. If they're found in the cervical spine, it can lead to associated scoliosis. And the thought is that these are inflammatory effects on the local paraspinal muscles, leading to asymmetry of the or asymmetric spasms of the surrounding muscles. Workup again is imaging. You can biopsy these lesions if there's a question of the lesion. And treatment, as I mentioned, for osteoid osteomas, pain is typically responsive to NSAIDs, though surgery is sometimes necessary. There is people that you can perform percutaneous radiofrequency ablation on these as well. And for osteoblastoma, these are larger lesions. Surgery is more commonly utilized for these, as well as radiation in some circumstances. Here we see on CT scan sort of that classic finding again. We see that central area of sclerosis as well as a radiolucent nidus around the lesion there. And here we see, this is osteoblastoma. We see hyperintensity on T2 and hypointensity on T1. Osteoid osteomas tend to be hypointense on both. Moving along to aneurysmal bone cysts. These are destructive expansile lesions. They are benign, though they can sometimes look quite impressive with involvement of the surrounding tissue. These cystic areas are blood-filled spaces, and they're connected with septations. These are typically found again in younger age, usually between the age of 10 to 20. Very rarely are they found in a population older than 30. Again, as I mentioned, they're found mostly in the posterior elements, though they can expand like this lesion here into the pedicle and epidural space. Pain as well as spinal cord compression and nerve root compression from these expansile cysts are the typical presentation. And on imaging, as I mentioned, they're classically this bubbly appearance. It's essentially pathognomonic for aneurysmal bone cysts. And we see these fluid levels of the blood-filled cysts within the tumor. Treatment can be based on size and presentation, anything from observation to surgery. A lot of these tumors could be treated with selective arterial embolization, sometimes often requiring more than one treatment, but that intervention alone is often all that's necessary, not necessitating a need for surgery. So that's one characteristic treatment option for these. Sclerotherapy, mostly for long bone tumors, but it has been discussed in literature for spinal aneurysmal bone cysts as well. So something to keep in your back pocket. CT scan here shows that characteristic modeled appearance. This is obviously an impressive associated compression fracture. And on the MRI, as I mentioned, it's a very classic, essentially pathognomonic bubbly appearance, very bright on T2 with those blood-filled fluid levels that you see. Continuing on, giant cell tumors sometimes radiographically can be confusing, and with aneurysmal bone cysts, these are also benign. They're defined as being composed of proliferation, of monoclonal cells among numerous macrophages and large osteoclast-like giant cells. These are somewhat common, rarely again found in the spine. About 7% of giant cell tumors are in the spine, typically in the vertebral body and in the younger population. And treatment options for these, again, surgery, whether an en bloc or an intralesional resection. And something specific for giant cell tumors is the use of denosumab, which is a monoclonal antibody specific for rankle, which, as I mentioned here, is something that's specifically expressed in these tumors. This neoadjuvant use of denosumab has been correlated with good disease control, allowing for either less morbid surgery due to the shrinkage of tumor or sometimes the avoidance of surgery in certain cases. We see the CT scan findings here. As I mentioned, it can potentially be confusing with aneurysmal bone cysts given the cystic nature of the tumor. And here in the recent spinal tumor surgery book released by Dr. Shuba, this is a case with an MRI finding of a giant cell tumor, and you can see the hyper intensity here and the associated compressive fracture and kyphotic nature of the patient. Moving on to malignant tumors, myeloma and plasmacytoma, as well as chordomas, will be the main discussion point here. These, again, are similar but different. These are the most common malignant pathology of the spine. Plasmacytoma tend to be less aggressive than multiple myeloma. Plasmacytomas tend to be solitary, whereas multiple myelomas are often multifocal. And prognosis is much better for plasmacytoma versus multiple myeloma. These are very radiosensitive tumors, often not necessitating any surgery unless there's any instability or acute neurologic compromise that requires the need for any surgery. On imaging here on the left, we see a isolated plasmacytoma with some soft tissue epidural component. And on the right, you can see every single vertebra in this patient essentially is involved with multiple myeloma. So very stark, tough to miss findings there. Osteosarcoma, this is this is the second most common malignant primary bone tumor. In general, these are mostly found in long bones, like some of these other that we've discussed. That's in the younger population. And as it's found in older population, it's actually more common in the spine. These can have osteoblastic and osteolytic mixed components to it. And the osteolytic component can lead to compression fractures and associated spinal cord compression. Treatment for these, as we do have a recent case of this, which we'll discuss later on this evening, requires wide en bloc resection when possible, and adjuvant chemotherapy and radiation when needed. Median survival for these tumors can be roughly about 10 months. This, again, from that same book as I mentioned before, is a case, and we'll present another case later on this evening, shows this mixed osteoblastic and osteolytic lesion with significant surrounding soft tissue involvement as well as epidural component. Chordomas, these are slow-growing malignant mesenchymal tumors. They arrive from remnants of the embryonic notochord. With that, there tend to be midline structures. They do have the potential to metastasize, so they're locally invasive tumors. That's their major pattern of growth. En bloc resection with wide margins is the treatment of choice, and we'll discuss some cases later on this evening with that. Some of these tumors are not amenable to surgery. We talk about the balance of neurologic compromise for oncologic cure and the balance between that, and important with discussion to the patients when we plan for this. Radiation therapy can help. Classically, people discuss proton beam therapy due to the important neural structures that are closely surrounding these tumors. The SBRT has also been recently discussed as a possible treatment option, both pre and post-op, though preoperatively it can lead to some more difficulties intraoperatively if and when the time comes, and we'll present one of those cases shortly. This is a picture from the same book that I've discussed a few times, just showing the extensive nature of surgery required for these complex lesions, often requiring multi-stage approaches for both separation and adequate en bloc resection. I'll quickly discuss two cases, one of which is a 61-year-old female. She presented with severe progressive back pain, and she was found on MRI and C, to have this sacral lesion, as you can see here. She had a CT guided biopsy that did confirm the diagnosis of chordoma. We'll quickly go through here on the axial CT. You could see this lesion involving the lower sacrum posteriorly. And as I mentioned, they're midline structure tumors typically. Here we see the mixed, the brightness on T2 that we see on these tumors. These are also heterogeneously contrast enhancing lesions. So for this patient, she underwent a two-staged approach. Anteriorly, as we see here, she underwent an ALIF at L5S1 for anterior column support and separation anteriorly. We see the use of a cadaveric femoral head where we cut out and created a wedge for the inner body for the L5S1 ALIF. At the same time, our plastic surgery colleagues, these are also often multidisciplinary surgeries. They harvested a rectus abdominis muscle flap, which is used posteriorly. Here we see the CT scan after the first stage with the L5S1 ALIF. And the following day, she underwent posterior for a near total sacrectomy with instrumentation. As we see here, once the sacrectomy was performed, this is the, we have the rectus abdominis muscle, which was pulled from the front to the back to cover the rectum that we see here. And this is our gross total specimen, as we see after the high sacrectomy with the preoperative imaging and the wide margin sample that was obtained after the second stage. And we'll just go through here. I know we're, for the sake of time, we'll cut to the second case here just to show a different example. This is a 64-year-old female. Initially was found with a small sacral lesion. This was watched. Unfortunately, it enlarged. She underwent a sheath biopsy, which is important to prevent local tissue seeding. It was confirmed diagnosis of chordoma. She underwent proton beam therapy. However, years later, it enlarged quite significantly, as we see here on the CT scan. And this patient underwent a total sacrectomy as well. Here on the MRI, we see this T2 bright tumor involving nearly the entire sacrum as well as surrounding soft tissue. This was, again, a two-staged approach, multidisciplinary with the placement of a ostomy bag. As you can imagine, the total sacrectomies involve necessary sacrifice of the sacral roots. Again, similar to the previous case, rectus abdominis muscle was harvested and a vascularized fibular strut was used to help with the reconstruction posteriorly. We see after stage one, she had a 2-level ALIF performed for anterior column support. And on the second day, she underwent a total sacrectomy. Again, you could see the rectum that was covered by the muscle flap and the fibular strut there that was used for reconstruction, beautifully closed by our plastic surgery colleagues. And we see the specimen here on the axial cut. We could see the full sacrum that was resected in an en bloc fashion, as well as in the coronal plane as well. And that's her post-operative reconstruction. So with that, we will quickly move on to the next. Let me just switch this here to the next presentation here. I'm not sure if there were any questions there, Dr. Shuba, that we should discuss, or if I should move on to the next slide for the sake of time.
I would just keep moving. Great job.
All right.
Keep up the great work. No questions at this time.
All right, we're going to keep on going. So next we have, so this will be a bit shorter due to the timing. This will be a general approach to workup of these as well as staging. And then Dr. Lowe will kind of take the alley-oop from there and discuss surgical decision-making for this. Again, from that Atlas of Neurosurgical Techniques, when building your framework of decision-making of treatment, imaging is and clinical presentation is often our starting point. We're going to focus on the right side of this, which is the primary tumors. And based on whether this is a benign or malignant lesion, will guide us towards what the correct management of these tumors will be. So the workup includes everything from imaging to what the patient's clinical presentation is, as well as histological diagnosis if and when it's obtained. And then the oncologic staging, we'll discuss the Anakin classification at the end to help with the decision-making on surgery. As I mentioned, pain is the most frequent presentation. I did mention this is worse at night and at rest. This is the classic oncologic pain. It's due to the cytokine release from the tumor tissue at night. This pain is progressive, though based on the presentation of the tumor, as I showed in the last presentation, these can have associated compressive fractures, which can lead to midline axial back pain due to these fractures, as well as mechanical pain due to associated instability. And if the tumor involves the epidural space or neural foramina, patients can also present with neurologic compromise or radicular pain due to the tumor extent. And as I mentioned, that would lead to the neurologic deficits. Typically, these patients that come in with neurologic deficits do have an overall worse prognosis, as I'm sure that's not too surprising to hear. Imaging, we discussed quite extensively in the last presentation. Some tumors have pretty classic findings, and based on that, treatment and patient education could be done, and sometimes further workup is necessary. Some of these tumors, as I mentioned, are osteolytic, some of them are sclerotic, and some of them are mixed. Based on the the extent of osseous involvement is part of the decision-making on treatment. Global spinal alignment is important. When patients present with this pain, we'll very briefly touch on a criteria that's used not necessarily to decide if surgery is to be performed, but to help guide us in understanding what the overall picture of the patient is. That's the SIN score, the spinal instability neoplasia score, not something we always think about with primary tumors. Again, the score is not to tell us whether or not these patients need surgery, but it helps us to understand at the time of surgery the extent of stabilization that may be necessary. The caveat of that is the extent of resection can also lead patients, maybe their SIN score is low, and after the necessary surgical intervention, it might tip them over into that unstable category. So this is something that's important to know, but again, it's not the end all be all at all, especially for these primary spine tumors, and especially for the malignant ones. It has been shown, though, to have near perfect inter and intra-observer agreement, and it's reliable even for us fellows to use when discussing and deciding on what to do in the middle of the night when these patients come in. So biopsy, some of these specimens do need biopsy to get a tissue diagnosis to help with decision-making as well as patient education. Typically, unless it's a pathognomonic radiographic finding, that's the next step. There are different techniques, needle biopsy, which is image guided, as you see on the top right. This is needle obtained needles used for obtaining specimen of the tumor. A trocar is used, again, as I mentioned, especially for lesions such as chordomas. Local tissue contamination is extremely important, and the use of a trocar helps to reduce that risk. Though at the time of definitive surgery, the biopsy incision and tract is incorporated into the surgery to ensure no local tissue contamination. Incisional biopsy can also be performed for some of these, which is a small incision that's made for obtaining specimen. And excisional biopsy essentially is removal of the lesion for biopsy purposes. I mentioned the major risk of biopsy with some of these tumors. And then oncologic staging, as we will discuss, the Anakin classification is one of those staging systems that can be used. It's based on 3 criteria: clinical, radiographic, and histologic findings. This was originally created in the 80s to stage tumors of the bones and soft tissue, and has been expanded and used in spinal tumors as well. And here we have a table demonstrating the Anakin staging system. The biologic aggressiveness, the grade of the tumor, ranges from these benign lesions to whether they're low or high grade malignant. And then the extent of local tissue involvement, whether it's involved within the tumor capsule and within the vertebral body, or if it expands out of the capsule and out into the extracompartmental space, increases its staging. And whether these have metastases essentially just kicks it over to the highest of grade. Very briefly, for us that need pictures to truly understand things, these are the benign tumors, how they'll present, 1, 2, and 3. Stage 1 for these benign lesions are all contained within a tumor capsule itself within the vertebral body. When these are active lesions, they can be having a thin rim capsule, sometimes enlarging. And when they become extra compartmental, when they start to extend out of the vertebral body and enlarge, is when it becomes a stage 3, though still the pathology is a benign lesion. And when we think of the malignant tumors, this is where we'll end. There are stages 1 and 2, and then A and B. So stage 1 are the low grade, and stage 2 are the higher grade lesions. And the separation of A versus B is whether it's maintained within the compartment of the vertebral body or it's expanding into the surrounding soft tissue or epidural space, as you see in that picture on the top right, that's showing an example of both. And when these are active, more higher grade malignant lesions, they don't have such a thick tumor capsule, and they're more involving of the surrounding tissues as well. Grade 3, there's no picture of it to show, but again, as I mentioned, that's anything that has associated metastases, which is important for decision-making on these patients. And with that, I will turn it over to Dr. Lowe. I will stop sharing my screen. Thank you.
Ross, that was a whirlwind tour. And although I've thought a lot about this for a long time, I don't think that was presented any better than you did. It really had the high points and depth was appropriate. We did look for some of the questions were being asked in question and answer. I think Dr. Lowe and I both responded. So again, if you have questions come up, please share. But for the sake of time, we'll keep going, and we'll now move on to Dr. Lowe's first talk on surgical planning based on Enneking classification. Thank you, Ross, and thank you, Larry.
Okay, thanks, Dan. So just for the first part of the talk, it's a little bit more didactic, talking about sort of historically how we've used the Enneking classification system, as well as the WBB system for understanding the tumor anatomy and making sort of recommendations based on margins. And then the second talk will be a little bit more sort of case-based, talking about in practice, sort of how we tackle these. My disclosures are irrelevant. We'll gloss over that for the sake of time. So basically, as Ross had mentioned, the Enneking classification was really, it's an old classification system that was actually used for sort of the extremities that was adapted for the spine. And that's part of the reason why some of the description is not perfect. So going really quickly, I think the TNM classification for HACC is a little bit more intuitive. At least that's what we learned in medical school and residency. I think the Enneking is a little bit less intuitive in terms of it breaks it down by the grade of the tumor, so the pathology-specific characteristics, the extent of local extension, whether it's intracompartmental or extracompartmental, and then the M portion is very similar to the TNM system, where it's basically the presence of remote disease. So, like I said, Ross already covered this, so we'll kind of skip over this. Another sort of classification that's used in conjunction with Enneking is basically the Weinstein-Boriani-Biagini classification. And this is specifically designed for the spine, so it's a little bit more intuitive in terms of communication between surgeons and understanding the tumor anatomy. So it's basically 12 equal sectors starting from the left side of spinous process and going counterclockwise. The traditional WBB classification was actually had an inverted spine, and the right left was inverted as well. But basically, the spinal oncology study group back in the 2010s or something like that recommended sort of a modified version. So this is basically the modified version where the spine is presented similar to how we look at a CT scan or MRI. So that's sort of the sectors. And then we have the layers of tissue. So basically, we're looking at the depth of involvement. So basically, A, if there's extra osseous soft tissue involvement, B, if it's superficial bony involvement, C, if it's deep bony involvement, D, if there's extra osseous, basically epidural disease, and finally, E, if there's intradural extension, that basically gets an E modification. And this vertebral artery involvement was added later on as a modified version to kind of help incorporate the cervical spine as well. And obviously the longitudinal extent is denoted by sort of how many vertebrae involved, like L2 to L4, something like that. So basically, Dr. Enneking, when he came up with Enneking staging, also proposed sort of essentially what are the recommended margins. And basically the goal for the surgery here is to achieve a resection principle that is consistent with sort of the Anakin classification while preserving the neurological function. And you'll always have to think about sort of what is the tumor-free window that we're going to use to deliver the tumor around the thecal sac or the spinal cord. And oftentimes, one of the things that we need to do is to sacrifice nerve roots. And if we do have to sacrifice nerve roots, we still have to dissect between the nerve root as well as the dural margin to actually put a suture around that nerve root that we're cutting. And there's specific challenges that are unique to the cervical spine or the sacrum, which I'll talk about in a little bit. But just briefly, the cervical spine obviously has vertebral arteries. A lot of the nerve roots are quite functional, like a C8 or T1 palsy is very, very symptomatic for the patient. In terms of the sacrum, we're talking about bowel, bladder, sexual function with the nerve root sacrifice, as well as proximity to major blood vessels and risk of a surgical site infection due to the fact that it's a dependent portion of the body and it's close to the anus. So if you look at sort of the Anakin recommendations for when we do an en bloc resection, it basically breaks down to three sort of categories. One is basically your benign aggressive tumors, and this is where we'll talk about adjuncts in a little bit, but traditionally the recommendation for lesions like giant cell tumors, osteoblastomas, was actually sort of a marginal en bloc resection. So for your Anakin stage 3, but it's the regular number 3 instead of the Roman numeral 3, or we typically denote benign tumors with the S in front of it. For low-grade malignancies, such as your chordomas or chondrosarcomas, so we're talking about stage 1A and 1B using the Roman letter 1 now. And obviously your high-grade malignancies in terms of your osteosarcomas, Ewing sarcomas for stage 2A and 2B, we recommend a wide en bloc resection. And the reason why we follow these principles is because it has a direct impact on survival as well as local recurrence. So if you look at this paper that was published in 2011 from the Spinal Oncology Research Group, they basically stratified the primary tumors into ones that got an Anakin appropriate resection versus one that got an Anakin inappropriate resection. If you look for both sort of survival function estimates as well as a direct plot for mortality, you see that essentially the Anakin appropriate patients do much better for survival. And I don't have the local recurrences graphs up, but it's the same thing for local recurrence as well. So based off of sort of this concept, we try to abide by these principles as much as possible due to the fact that we know patients do better. And basically there's these plots that we can use. And I'm going to be perfectly honest with you, like this is something where I generally don't look at this, but I think it is an intellectual exercise to go through these for sort of your more straightforward cases. So basically, obviously, you grade the tumor and the stage based off of the Anakin principles. And based off of that, you come up with sort of a recommended surgical margin. You use the WBB staging to look at the sectors that are involved, as well as the layers of tissue that are involved, and then you come up with a recommended surgical procedure. So traditionally, now there's a lot of nuances to this, but big picture, traditionally, there's kind of like 3 approaches that we use. Basically, a 2-stage vertebrectomy, a 2-stage sagittal resection, or a single-stage posterior arch resection. So in terms of the 2-stage vertebrectomy, basically the tumor has to be confined within sectors 4 through 8 or 5 through 9. And basically the traditional teaching was that one pedicle needs to be free of the tumor. And the reason why one pedicle needs to be free of the tumor is that you need to work through that sort of uninvolved side to dissect the thecal sac or dissect the spinal cord dura. You have to be able to kind of tease the plane between the posterior longitudinal ligament as well as the dura. And so traditionally how these were done was the posterior elements would be removed in a piecemeal fashion. You would do a unilateral or bilateral pediculotomy, and that would be the first stage. And then the second stage, you come in either to the front or through the side to basically deliver the tumor en bloc. In terms of a sagittal resection, it's basically very similar principles. We're talking about unilateral lesions that are confined within zones 2 through 5 or 8 through 11. And basically the vertebral body in this situation is split in the sagittal plane to allow a clear margin from the lesion. And we do the same thing with the posterior elements as well. We typically obviously come in sort of through the side to deliver this en bloc, and this is traditionally sort of a 2-staged approach as well. And finally, if the tumor is completely confined within the posterior elements, meaning we're talking about your zones 3 through 10, then the posterior elements are resected through a single posterior approach. And we basically section the pedicles from the outside in, and we lift the posterior elements off for an en bloc resection, looking at sort of the posterior elements. So sort of going through like the cases. So this is sort of a more of a chip shot case that kind of, or not chip shot, but a more straightforward case that combines with these principles. So if you look, this is basically a lady in her 40s that has a newly diagnosed biopsy confirmed L5 chordoma that's predominantly confined within the vertebral body. You see that it's basically well confined within the vertebral body. There's minimal epidural extension. There's no involvement of the bilateral nerve roots. It's truly all in the anterior column. You see the same thing on the CT scan as well, is that you see sort of the lytic changes from the chordoma all being sort of confined within the anterior vertebral body. And obviously there's really not a lot of epidural extension other than in the dead center where it's broken through the posterior cortex right there. So using sort of this worksheet, if you will, so this is basically a low-grade malignant neoplasm, so G1. It's all confined within sort of the single compartment of the vertebral bones. I would say this is a T1 lesion, and her staging scans were negative, so M0, so this would be an indicating stage 1A. And based off of that, we would recommend a wide resection. And if you look at the WBB staging in terms of the tumor anatomy, basically it's confined within the anterior sectors from 5 through 8. And if you look at the layers that are involved, it involves the superficial bone, it involves the deep bone, and it barely involves the epidural space. You can make an argument on to include D or not, but basically the bottom line is based off of this, the recommended surgical procedure will be sort of a 2-stage vertebrectomy. So how that is done, like I mentioned, is that we come in through the posterior stage first. Rather than sort of removing the bones piecemeal, we typically use sort of either osteotomes or an ultrasonic bone cutter now to kind of at least get as much of it out cleanly as possible. So basically the lamina is removed sort of in a clean fashion, just in case we're misdiagnosing the patient and there's actually tumor in the posterior elements. And once the epidural space is exposed, we then basically dissect the epidural planes. That white thing that you see with the star there is basically the epidural elastic sheath that's laid down there to protect the neural elements to help make stage 2 or the anterior delivery safer. We perform a reconstruction using a pedicle screw and rod system. And we lay in a structural allograft to help the bones heal, because presumably this is a curative operation. So we really do need an arthrodesis to occur across a big gap in order to help prevent hardware-related complications. This is just a 3D rendering through the side where it kind of shows that essentially we want to carry that dissection, especially the lateral annulus dissection, as far anterior as possible, because coming in from the front, especially this lady had a bigger body habitus. It's actually not easy to come all the way through the side, depending on the extent of exposure and sort of how big the psoas muscles are. So you want to do as much as possible coming in from the front to dissect the lateral annulus. And then in terms of the anterior delivery, we basically deliver the tumor after dissecting the aortic bifurcation and iliac bifurcation with the help of our vascular surgeons to deliver it beneath the bifurcation. You can see sort of in the middle panel that you can see the fecal sac. You can see the bilateral L5 nerve roots. You can even see the fibular graft, as well as literally the tip of the Blake drain that was placed from stage 1. And this is the specimen. And then obviously you would want to perform an anterior column reconstruction as well to try to maximize your chances of bony healing. So I would say this is like a case illustration that really confines very well to the traditional Enneking and WBB principles. But then I do think that there are significant limitations to this. And I think one thing that we always struggle with is this question of surgical margins. And obviously the second thing that's limiting for the WBB and Enneking is that there's really a lack of clinical context, right? Where we take into account the performance status of the patient, the frailty of the patient, the adjuvant treatment options, as well as the long-term functional consequences of the proposed surgery. So talking about margins briefly, basically, when the tumor involves the epidural space, a wide margin is really only possible if you actually resect the dura. By definition, if the tumor comes in contact with the dura and you're dissecting in between them, you're actually on the pseudocapsule of the tumor. And by definition, you have a marginal resection. So really, oftentimes, we're actually doing a marginal resection whenever the tumor actually involves the dura or involves the epidural space. And we only reserve the dural resection for cases where the preoperative studies or the intraoperative findings truly suggest that there's actually direct invasion of the dura by the tumor. And the reason why that's important is because if we do go intradural to resect the dura with a specimen, obviously the fact that we have a CSF leak, it does increase the complications from the surgery quite a bit. And sometimes it's not practical. And sort of, I have a good case that kind of shows the demonstration of that is that this is a 53-year-old gentleman that basically presented with sort of a slowly enlarging neck mass over the course of 15 months. God knows why he didn't want to treat it sooner. But anyways, if you take a look at this tumor, it's obviously sort of involving multiple compartments. It comes in contact with basically multiple nerves, multiple blood vessels, and multiple bones. And it's obviously quite large, spanning from the occiput going out down to T1. And if you look at the MRI, there's definitely areas of the bone that look quite suspicious. I think the suboccipital bone looks okay, but then clearly, if you take a look at the posterior elements, it seems like there's some, so that's the C2 spinous process that's coming up, and you see that perhaps there could be some suggestion of infiltration there. Same thing with the C3 spinous process. And if you go down, essentially it comes in contact with every single spinous process on the right side, going all the way down to C7. And T1 is really when the tumor starts to curve around and falls above it. So if we use the grading system for something like this, using the traditional Enneking in the WBB system, this basically grades out to a 2B lesion because of the histology. So the needle biopsy came back as basically high-grade malignancy, suspicious for sarcoma. So the recommended surgical margins for that would be definitely wide. And if you look at the zone, it basically involves zone 1, then zone 12, 11, 10, 9, and maybe a little bit of 8 or it stops at 8, but basically this quadrant here. And if you look at the layers, it's definitely very superficial. Right? It involves, it's mostly extraosseous and it possibly involves the superficial bone. So if you look at the recommended surgical procedure, it doesn't really fall in cleanly with any one of the 3 categories, right? Is it a posterior arch resection? Are you gonna take a little bit of the lateral mass? So this is where the concept of this wide surgical margin becomes a little bit hairy, particularly in the spine. So if you look at the surgical margins for this patient, if you look at the bony structures that the tumor is touching, so technically you have to take these bones with the specimen to truly achieve a wide margin. It's touching the suboccipital bone, it's touching all of the spinous processes from C2 to C7, and it's coming in contact with the lateral masses from C3 to C6. If you look at the neural elements that are coming in contact with the tumor, basically the extraforaminal portion of the nerve roots from C2 to C7 are all being pushed forward by the tumor. The vagus nerve, the accessory nerve, the hypoglossal nerve. The phrenic nerve was being displaced anteriorly, but there's a little bit of cushioning from the scalenes. And if you look at the vessels, it basically comes in contact with common carotid, external and internal carotid, with getting branch vessels from both the external and the internal. It's directly in contact with the internal jugular vein. It's also getting branches from the vertebral artery, which I'll show. So the reason why that's important is preoperatively, we elected to coil the feeders coming from or coil as much of the feeders as possible, not because we were going intralesional, but because we wanted, because the tumor is so large, you don't really have the mobility to actually directly dissect the vessels on and put a clip on it. So there's a pretty high probability that as we're rotating the tumor that we're avulsing the perforators. So basically the coil embolization was just to make the delivery a little bit safer. So we basically coiled branches from the external carotid artery, as well as the thyrocervical trunk that was feeding the inferior portion of the tumor. But if you take a look at this diagram, you see that on the right vertebral artery injection, it's actually getting significant pipes, big feeders, particularly at the C1, 2, and C2, 3 area from the right vertebral artery. And unfortunately, our neurovascular team was unable to get a microcatheter to selectively coil these without occluding the parent vertebral artery. So then the surgical strategy that we were going to take was to basically mobilize the tumor as much as possible and then remove sort of the pedicle attached to the occipital cervical junction and C1-2 junction last to get the room to basically skeletonize the right vertebral artery and basically clip these feeders. And obviously, for example, because that's our surgical strategy, one of the things, if If it were possible that those vertebral artery feeders were going to be coiled properly, then we might have potentially been able to do a suboccipital craniectomy as a last step, because everything else would be mobilized and we basically run a craniotome through that. But unfortunately, that surgical strategy does preclude upfront dissection away from the suboccipital bone first, because we want to get the tumor as free as possible to get it sort of free on its vertebral artery pedicle. So sort of this is how we position the patient. Obviously, the tumor is grossly visible. And see sort of like the views that we're getting intraoperatively are sort of very unusual in that this was an all posterior approach. And you see that coming from posteriorly, we're actually dissecting the carotid sheath. We're dissecting essentially the internal jugular vein away from the tumor. We're dissecting the common and the internal and external carotids away from the tumor. And you see a glimpse of the vagus nerve there. And then deeper, we actually dissected the hypoglossal, so it's the phrenic nerve all away from the tumor. And this is sort of the last step where we're basically just freeing up the last pedicle. Unfortunately, the video wasn't shot on the other side. We could actually see the pedicle and see the clips on the vertebral artery perforators to deliver the tumor. And part of the reason why, so another thought that went into sort of not resecting the lateral mass. So for this specimen, we basically resected the spinous processes, but we elected to leave the lateral mass. And the reason why we elected to not actually cut along the length of the lateral mass was that, first of all, in the MRI, it wasn't entirely clear that there was gross involvement, unlike the spinous processes. But also, if you take a look at the soft tissue reconstruction, for a tumor that's this large, the soft tissue reconstruction is actually a big part of the case. So if you take a look, you see that there's basically really very little soft tissue there. And if we have placed spinal implants, there will be significant concern about hardware erosion through that thin skin flap. So that's also another reason why we didn't cut the lateral masses. And sort of another case that kind of doesn't really conform very well to this is a patient with metastatic osteosarcoma. So this is basically a lesion in the right sacral ala that extends across the sacroiliac joint on the right. Same thing on the CT scan. In terms of having sort of this well-circumscribed lesion in his right sacral ala. And if you use the staging system, by virtue of this being a metastases, the recommended surgical margin would be none, because this would be palliative, and therefore there would be no recommended surgical procedure. But let's take a look at that into clinical context of the patient. This is a 20-year-old gentleman. His initial diagnosis of osteosarcoma was in the left tibia. He had a local recurrence in June 2018. Then he had a remote disease at L3, which was left acetabulum that was resected en bloc. His most recent PET scan this year showed no pulmonary nodules, and there was only isolated FDG update in the right sacrum. His performance status is quite good, even with the radiculopathy and the pelvic pain from the lesion. His KPS is 80. And prior to that, at the end of last year, he was actually more like 90. He just had a little bit of sort of limp from the prior surgery with the L3 nerve root sacrifice. And he's not frail at all due to his young age. So if you take the WBB and the Enneking recommendation verbatim, this patient wouldn't get surgery. But obviously, the clinical context puts everything else into, it makes things a little bit less clear cut. And we recommended an en bloc resection for this. So we did a 2-stage surgery where we basically cut the right S1 and the S2 nerve root and delivered the tumor posteriorly. This is the reconstruction with the VRAM flap, and this is sort of what the bony reconstruction looks like. And basically the patients, this is a more recent case. The patient's about 3 weeks out now in rehab, but he's already walking with a walker. And if you take a look at the margins, and this gets back to the margin issue again, of course, our ventral margin abuts the tumor, and then our superior margin abuts. So the ventral margin, basically we dissected the iliacs, internal iliacs that were sacrificed, and we sent that separately as pathology, and that was negative, so that's okay. But the superior margin, we would actually need to sacrifice the L5 nerve, which we preserved, to actually get a healthy superior margin. So this is where I think that a lot of these tumors that are actually within the spinal canal or close to neural elements, by definition, are always marginal unless you're willing to do something radical like ligate the thecocycle, cut the nerve roots that are basically uninvolved. So basically, the Enneking classification in the conclusions guides the choice of the surgical margins and appears to be valid in predicting the prognosis. The WBB classification is more sort of an anatomic thing specifically tailored for the spine, and it helps guide the type of resection that you're going to do. But essentially, there's limitations for both classification systems, particularly as it regards to surgical margins, as well as the clinical context of the patient.
Yeah, Larry, this is a great presentation, and you show some of these wonderful cases that I know you spent a ton of time planning and then operating on. Um, I think that for the as you get your next talk ready, I think people, what I'm taking from this talk, and I hope it's taken, is that it's great to have a baseline. And a lot of people put a lot of time into the WBB and into the King and into TMN, but then each patient is individual. So I think it's probably wrong to sit there and say I treat every patient like a blank canvas and an art. We'll just throw everything out every time and start anew. That's wrong, because you're going to not take advantage of a lot of things that people have taught. On the other hand, if you sit there and say, I read the textbook and this one says, in any patient who has this, you're going to miss the opportunity to really treat the patient individually with maybe something that you or your team or your university or your hospital has that can help them. So I think to round this out, the final talk is going to be on considerations. When is it even feasible, so that we include the multidisciplinary aspect? And if you say it's not always a surgical disease, and how do we include other people in this decision? Thank you, Larry. Go for it.
All right. So basically, I think that in practice, at least this is how sort of we think about it here. I think the three factors that we always think about is the patient-specific factors, the pathology-specific factors, and the morbidity of the proposed operation. So I think the patient-specific factors are pretty straightforward. We're talking about the age, the medical history, the performance status of the patient, how frail they are. I think the pathology-specific factors are a little bit more nuanced. We're talking about the likelihood of local recurrence based on the histology, its metastatic potential, the effectiveness of alternative treatment options if the patient were to forego surgery or undergo an intralesional operation. And I think this one's key, where what is the incremental benefit of en bloc versus an intralesional gross total for local control and overall survival? And finally, the overall survival expected based on their cancer. And then the surgery-specific factors are basically collateral damage by an attempted en bloc resection in terms of the nerve, the blood vessels, the viscera, the soft tissue that we have, the soft tissue reconstruction that we need to do, as well as the long-term functional consequences from that. So we'll kind of go through a couple of cases to talk about that. So basically, this is a 54-year-old physician that presented with predominantly sort of a dorsally situated mass that has this bubbly appearance, causing a little bit of spinal cord compression, get some tingling in his arms. If you take a look at the CAT scan, basically you can see that the entire posterior elements have already been replaced by this mass, but basically it's predominantly confined in the posterior quadrant or posterior sectors. So if you look at the patient-specific factors, 51-year-old gentleman, no medical history, good performance status. He just has neck pain and a little bit of tingling, and then not frail at all. So if you look at the pathology-specific factors for this, so this ended up being an aneurysmal bone cyst, but the outside hospital pathology read it as osteoblastoma. So this was a stage 3 by King, which would predict a 13% local recurrence rate. It's a benign tumor, so it has no metastatic potential. In terms of effectiveness of adjuvant treatment options, radiation is pretty controversial. Traditional chemotherapy is not very effective. And basically, there's really no local recurrences reported for an en bloc marginal wide resection versus a 23% for intralesional. And in terms of survival, we don't really think about, we don't think of survival because we expect it to be near 100%, because osteoblastomas shouldn't really affect our survival. So if you look at the proposed operation that will be necessary, we could probably get away with one of those posterior sector operations. So really, we don't have to take any nerves, we don't have to take any blood vessels, we don't have to take any of the viscera. The soft tissue defect is quite small. We obviously have to perform fusion. So in terms of the long-term functional consequences, there's a little bit of loss of subaxial spine cervical mobility. So if you take these factors into account and tabulate it into an en bloc score, if you will, the patient himself is highly favorable. The pathology is, I would say, mildly favorable, and the surgery is highly variable. So we would do an attempted en bloc for this. So we did an all posterior approach. We got negative margins on this. The final pathology came back as aneurysmal bone cyst. If you look at the post-op scans, you see that essentially we do a single level reconstruction. And it's kind of subtle, but there's a little bit of radiolucency in that right pedicle. So presumably that's this patient's going to have a local recurrence. So presumably we potentially had left some tumor there. So a year later, of course, you see that now this patient does have a local recurrence. And it's basically now it's involving the right hemivertebrae, and it's also wrapping the right vertebral artery right there as well. And basically now we have a pathological diagnosis of aneurysmal bone cyst. This was re-biopsied to be an aneurysmal bone cyst. And basically, if you look at the patient's specific factors, he still remains a good candidate for surgery. We re-biopsied it. In terms of metastatic potential for an ABC, there's no metastatic potential. In terms of alternative treatment options, Ross alluded to this, but selective arterial embolization is effective, but requires multiple treatments. Sclerotherapy is a little bit controversial. Radiation is controversial. Denosumab and bisphosphonate seem to be effective, but we typically reserve those for sort of non-surgical cases. And same thing as osteoblastoma, where an en bloc resection seems to basically be curative compared to a 7% local recurrence rate for intralesional. Now, there is more collateral damage from the surgery. So we likely have to sacrifice the right C3 nerve root. We have to sack the right V2 segment of the vertebral artery. There's a minimal soft tissue defect. So the long-term potential functional consequences might be an elevated hemidiaphragm, numbness, or even a possible stroke. So I would say for this patient, the patient himself remains highly favorable. The pathology, I would say, is neutral to mildly favorable, and the surgery is neutral. So the decision that we made was to attempt an en bloc only if the patient was able to tolerate a right vertebral artery occlusion by a balloon test occlusion. So he was able to tolerate that, and therefore we proceeded with an en bloc operation. And we sent the fusion mass bone that was laid down over the rod separately, and this was actually positive for focal residual aneurysmal bone cysts. So postoperatively, the patient got denosumab as well as SBRT as part of the adjuvant treatment paradigm to try to minimize the chance of a local recurrence. So these are what the post-op scans look like. Let me skip a couple of these just to kind of get to the more interesting ones. So this is a patient with an L5 chordoma. He's actually a physician as well. He presented with basically back pain, and he has this massive tumor at L5, and it's multi-compartmental. It goes into the spinal canal, it goes into the paraspinal soft tissues, and it also involves the retroperitoneal space, and even retroperitoneal space on the left as well. And this is what the CT scan looks like, showing that's a multi-compartmental tumor. So if you look at the patient-specific factors, again, otherwise healthy 59-year-old gentleman, good performance status, has no radiculopathy or any bowel bladder issues somehow from that tumor, not frail at all. If you look at the likelihood of local recurrence for a conventional chordoma, it's actually quite high, right? 26 to 78%. It definitely has a small but non-zero metastatic potential. In terms of alternative treatment options, there are definitive radiotherapy trials that are going on for chordomas, and it's kind of institutionally based, especially if you have heavy ion radiation overseas. But generally speaking, we do consider sort of traditional chemotherapy to be ineffective and definitive radiation therapy to be investigational. If we do an en bloc resection for this, it's a threefold reduction in local recurrence, but it's not quite as dramatic as something like a chondrosarcoma or an osteosarcoma. And if you look at sort of machine learning algorithms from the MGH Spinal Oncology Research Group, the 5-year survival from this is expected to be quite high, approximately 65%. So if you look at the collateral damage from this, because the tumor is basically encompassing all sectors, we actually have to ligate the thecal sac if we really wanted to be en bloc about this. We don't have to take any blood vessels or viscera. There is a pretty sizable soft tissue defect from this. So if we ligated the thecal sac at L4, we would have bilateral flail foot. The fusion would basically lead him to have loss of lumbosacral mobility. And would have loss of bowel, bladder, or sexual function completely. So if you look at this sort of en bloc score for this case, the patient himself is highly favorable. The pathology, I would say, is moderately favorable, but the surgery, I would say, is highly unfavorable. I would say most people would argue that a thecal sac ligation at L4 for a chordoma is a bit aggressive. So our intent going into surgery was an intralesional gross total. So our initial strategy was to go in through sectors 11 and 12, where there was no bony tumor, and get access to the epidural space and do the epidural dissection to basically be intralesional in the epidural space, but then roll the rest of the tumor out en bloc. And we were very fortunate with this lesion because what ended up happening was that once we actually got into the spinal canal, there was actually very good planes between the chordoma and the dura. And more importantly, the tumor had actually already caused a contralateral pedicle fracture. So we were actually able to rotate that spinous process and open the window into the spinal canal so that we can actually ligate the contralateral nerve roots. So we were actually able to stay out of the tumor capsule the whole way and resect the tumor en bloc. So we were very fortunate with this case, but again, at least going into surgery, we're not going to ligate the fecal sac at L4. And again, it's one of those things where if you follow the WBB and the etiquette recommendations verbatim, you have to do a wide resection and ligate the fecal sac. But you see that in this case, we're able to still achieve a marginal resection without actually, I would say that his deficits are tolerable. He's actually walking without a walker or a boot now. He's about 7-8 months out from surgery now. So I do think that there's other cases, but I think we're running short on time, so we'll cut it short. But basically, these are sort of some of the principles that we use in practice to think about how we resect these tumors. And didn't get a chance to talk about a lot of the adjuvant options, but the bottom line is sort of, for these tumors, it takes an army of people to take care of these patients, right? Like your radiation oncologist, your medical oncologist, you basically need a plastic surgeon, vascular surgeon, surgical oncology. There's just a lot of people that are involved taking care of these patients. And I think that the key thing is that you want to have this multidisciplinary approach, but also like, I think the WBB and Anakin is good for sort of an underlying framework, but each tumor is different, right? I showed you multiple cases where we did not conform to the WBB and Anakin sort of recommendations. So I think that wraps it up for me, and we'll take any questions at this time.
Again, great job and way to think about patient, procedure, and pathology. I think that's true of everything we do, whether it's trauma, whether it's deformity, whether it's tumor. We got to think about the patient factors, as you said, the actual injury or pathology, and then the technique and how big it is. I'd like, as I leave this, I think about some of the controversial issues, and I think we've done a great job. We're going to finish up in a couple of minutes, but Larry, if you could answer this question for me. I don't want to bias it too much because I have some thoughts on this, but I think as a person who say doesn't do this as much, there's literature out there that says, hey, we're getting better and better with radiation. We're getting more and more energy delivered, whether it's in photons that are focused or particles such as protons or carbon ions. Hey, why don't we just blitz it? Because these surgeries are tour de forces. They're extremely risky. And hey, with Ewing's and osteo, they get radiation anyway. Throw chordoma in there and we'll radiate that one too. And we avoid all this. Any comments on that with your experience?
Obviously, as you know, I'm biased about this. And so we got asked actually the same question at the spine section as well. I think that it really represents sort of like an institutional expertise in terms of what the best option is for the patient, right? So I do think that, for example, that operation that we did in terms of that L5 chordoma, where we were fortunate in terms of being able to resect that en bloc, I think that that's a very challenging case. I remember that we finished at like 10, 11 o'clock. It was some obscene time in the evening. And I think that if that's your first en bloc that you're doing, it's probably not going to have a good outcome. And same thing with the radiation too. The same goes for radiation, where if you're not used to delivering 50, 60 grays to the tumor and taking the core tolerances up to 14, 16, or even 18 at the risk of radiation-induced myelopathy, you're not really going to have a good outcome for local control from the radiation. So I think that I think the correct answer of what should be done really depends on sort of what the institution expertise is. I think that if the en bloc resection can be done safely with sort of acceptable morbidity, we do that. And that's obviously based on surgeon bias in terms of what he or she's good at. On the other hand, if you at a heavy radiation center where they're basically very gun shy about radiating and they're not willing to deliver 50, 60 grays, or they stick to the 10 gray cutoff for the spinal cord, you're probably not going to get good outcomes from radiation either. So I think that ultimately you want to go to a center that's experienced at treating these, but also there's definitely institutional bias as to what they're better at. And I think that depends on their personnel, so what they're experienced in doing.
I couldn't agree more. I obviously am biased as well. We have a lot of similar thoughts on this. Ross, I don't know if you went to bed yet. I know we only got a minute left, but if you're back awake, good. So real quick, you're finishing up your fellowship. And as we go out there, this meeting is both for learned, wise older physicians as well as junior ones. Comments as you spend more and more time on spine as a neurosurgery resident. What are your thoughts about as you go through a fellowship, just to kind of share with other people who are thinking about spine fellowships about, does exposure matter? Does reps matter? And what would you recommend to young surgeons out there who are thinking about doing extra fellowship time?
Yeah, I think fortunate coming to through as a neurosurgery resident, we get early and lots of exposure in spinal surgery. I think the focused year of a fellowship for me at the end of my training has been great to really dive in and get the full experience from outpatient to intraoperative experience. Doing some of these big cases really gets you to think everything from the instrumentation to the patient perspective. You look at an MRI and you want to just jump in and do surgery, but it really helps to take a step back and look at patients as a big picture. And I think it's really helped me with that. I think the training has been great thus far. I strongly recommend it for all of those, and look forward to my future residents joining.
Well, thank you. Thank you to everyone here, Larry. Thank you for answering some of those questions in the meantime. And thank you to the entire AO Spine staff. This is such a delight, and we really enjoyed putting this out there, and hopefully it stimulates some thought. We're all always learning. So as you know, hopefully the people that know me, I'm free with a phone or with the email, because I learn every time someone shows me a challenging case, and we really enjoy it. So I think on behalf of Dr. Lowe and Dr. Green and the entire team here, please don't hesitate to reach out to these people through the AO or through our institution or through any other societies, so we can all continue to learn. And with that, we'll conclude. And thank you all for your participation and your engagement tonight.